First up, we have Dr. Judith Owens from Boston Children's Hospital and Harvard Medical School discussing the results of a study we published together in Sleep Medicine fairly recently. Her talk is titled Melatonin Use in Infants and Toddlers. So, Dr. Owens, I'm going to hand it over to you.
Honored to be part of this group. I know some of you admire your work, and I'm eager to hear about the work of the other folks joining us today. So this is a very exciting opportunity to potentially collaborate and share what we're really about. So I'm hoping this will work. Oh, it may not. So what I was hoping to share with you, I just reviewed 330 TikTok videos on melatonin use. And you would probably be shocked to see what is going on out there, ranging from vaping melatonin to melatonin spray, to melatonin diffusers, to using melatonin during the day. And perhaps the most insidious piece of this was sneaking melatonin gummies into children's fruit snacks, which there were quite a few videos on. So you'll have to take my word for it, but we're in the process of writing this up, even though TikTok may not be an entity in our country for much longer. So you may know that melatonin in the United States is very minimally regulated by the federal government. It's considered a food additive by the FDA, which means that it does not require clinical trials. Very minimal monitoring of the use, and also the content and validity of melatonin products out there. And, this is not just a US problem, because I think in a lot of countries around the world where melatonin is available appropriately by prescription only, caregivers have started to go online and purchase products from the United States. I'll talk about in a minute how that is a real problem. So, we know the caregivers and healthcare providers, and we've done some qualitative work in interviewing healthcare providers about their attitudes towards melatonin, generally tend to view it as natural. And partly as a result of that, but I think partly as a result of marketing, pretty aggressive marketing, melatonin use in the United States has increased astronomically over the past decade. And we have some survey studies which suggest that, but we also have some studies looking at calls to poison control centers, for example, that involved melatonin, which have gone up 530% in a decade, as well as visits to emergency rooms, and other evidence of accidental ingestions of melatonin. So the level of concern has risen substantially because of these reports of accidental overdose, and also several studies which have shown conclusively that melatonin content compared to what is advertised on the label is often dramatically different. For example, in a study of gummy products, which is what most children are exposed to, they found that only 12% of the products that they tested via chromatography had a content that was plus or minus 10% of what it said on the label. And that is kind of the standard that FDA requires of over-the-counter products like melatonin. So 88% did not meet that standard. And so professional organizations, not the American Academy of Pediatrics to my knowledge, but other groups like the American Academy of Child and Adolescent Psychiatry and American Academy of Neurology have issued basic guidelines about melatonin use that pretty much say appropriately that caregivers should consult a pediatric provider before using melatonin, and emphasizing behavioral interventions as the first line of treatment of insomnia, as well as emphasizing the safety concerns of accidental overdose. But particularly in the United States and in many other countries around the world, because melatonin is not required to be prescribed, and clinicians oftentimes lack the time and the expertise, the knowledge fund to implement appropriate behavioral interventions, melatonin has increasingly functioned as a standalone option. So the aims of this study were to look at safety and efficacy of melatonin, particularly in use in children less than 2, but the age range was actually 0 to 36 months. And I'll explain a little bit about that in a minute. And we also wanted to examine why caregivers were giving melatonin to their very young children. So this was a sample of over 158,000 of US-based caregivers who had Nanit baby monitors and were invited to participate. And we collected some basic sociodemographic information, melatonin use and frequency, and we also did a BISC-R, which is the Brief Infant Revised Questionnaire. And so we conducted a descriptive analysis of these various parameters. So a small number, percentage, as you might imagine, of caregivers, but still it represented 3,000 respondents to the survey. And the vast majority of them, 98%, thank goodness, reported they had never used melatonin for their child, while around 2% or 53 respondents reported having used melatonin at some point. And there were no differences among the users versus non-users in terms of income level, education, or caregiver age. So sociodemographics were essentially the same. So about close to half of parents had received their recommendation to use melatonin from their pediatrician or healthcare provider. And that's a double-edged sword, right? Because we shouldn't be using melatonin in children less than 2 years of age, but at least they were asking their pediatrician or a medical provider about whether or not to use it. However, about half of parents received their information from alternative sources, which may have included TikTok videos, but especially relatives and friends, presumably who had tried melatonin for their own children. So the most common formulation was liquid, followed by the gummy preparation, which I think is a particular safety issue in terms of mixing up these gummy formulations with other candy-like substances for children. So this is just a more detailed description of the gummy study, which looked at 25 different brands that were purported to have 1 to 10 milligrams of melatonin. And they analyzed these products for melatonin, CBD, and serotonin because a previous study of over-the-counter melatonin products had shown that about 26% also contained serotonin, which is a precursor of melatonin. So the actual melatonin content ranged from 1.3 to 13.1 milligram per serving size. And there was a huge variability in terms of the actual quantity. As I mentioned, 88% were inaccurately labeled, 12% met that standard of plus or minus 10%. And they did find some products which actually contained CBD. And so the authors concluded that consuming melatonin gummies could expose children to 40 to 130 times the normal nighttime plasma concentration range in a young adult, for example. So these are some of the reasons that parents mentioned using melatonin. The most appropriate one being to reduce difficulties falling asleep, because these were presumably all short-acting melatonin preparations. But when you look at the other indications, things like adjusting to a new sleeping environment, more restful sleep, and that I think is a direct reflection of some of these marketing claims that promote on the label of melatonin for children for peaceful, restful sleep. Better sleep quality, time zone, increased total night sleep, reduce the number of night wakings, which melatonin does not do. So there were a lot of essentially inappropriate indications for using melatonin. What I thought was really interesting is when you look at the BISC scores, which indicate that caregiver perception of sleep in their infant as a problem or not a problem, was not significantly different between those who had or had not used melatonin for their child. So I think, again, this reflects the aggressive marketing that essentially puts forward melatonin as a solution to get your child better sleep, kind of like a vitamin. So in other words, your child doesn't have to have a sleep problem in order to use melatonin, which I think is truly concerning and insidious. So overall conclusions were that a small percentage, again, thankfully, of this caregiver sample had reported using melatonin. About half had received a recommendation from a source other than a healthcare provider, and so may have not consulted or even let their healthcare provider know about this. The reason for using melatonin for a number of respondents was not directly linked to an appropriate sleep problem. And again, this lack of correlation between melatonin use and the increased scores indicating sleep problems on the BISC-R may reflect these marketing drives, really. So these findings add to the growing body of literature that are raising legitimate concerns regarding the explosion in pediatric melatonin use in the United States. And, you know, we as particularly those of us who are treating children clinically really need to pay attention to this and get the correct information out there. And to be aware that there's this high level of inaccuracy of label claims versus actual melatonin content that may be more of a global issue than we had previously thought. So, you know, in general, this supports the need for both caregiver and healthcare provider education regarding melatonin use. And I think we need improved regulatory oversight of available products. Now, depending who ends up being our head of Health and Human Services in the United States, I won't share my opinion about that, but we may be in trouble in terms of having more regulatory oversight. The good news is, so we published this, as Natalie mentioned, in Sleep Medicine last year, but hot off the press is a technical report that on melatonin use in managing insomnia in typically developing children. And the reason we've focused that set of recommendations and information is that there's a very small literature. The literature on use of melatonin in children with neurological disorders like autism is much wider. But that's why this is a consensus the second document is a consensus report because it's based on the literature, empirical evidence as much as possible, but also because of the lack of data out there, it also is expert consensus. So the first document is actually in press in sleep medicine, and the recommendations for healthcare providers, which echo the information that is in the technical report, is under review. I'm about to submit the revised version, and I'm hoping that the two will be published simultaneously. So thank you for your attention. I'm happy to take any questions if there's time, but if not, thanks.
Amazing. Thanks. Judy, do we have any questions? If anyone wants to put a question in the Q&A, they are welcome to do so. In the meantime, I just wanted to ask you a question, Judy. You suggested we work to get this information out there. How do you think, with the rise of TikTok and all these other social media platforms, what do you think is the best way to counteract these trends of increasing use of melatonin, and what's the best way to get this information out there?
Well, I think it does have to get out in reliable social media outlets, depending on what you think those are. I do think that the American Academy of Pediatrics needs to take a strong stance on this. And to my knowledge, they just have not. And what is posted on their website is an article that's now a couple of years old, which actually suggests giving melatonin to teenagers whose schools start too early to try to force them to fall asleep earlier. So, I think at least in the US, the AAP is kind of the arbiter of good health for children. I will say that, they haven't stepped up to the plate, and that's why the International Pediatric Sleep Association really felt strongly that we need to come out and be a strong voice for, and it's not that melatonin is bad, but it's got to be used safely, judiciously, for appropriate indications, not in children under the age of 2, with almost no exceptions. Well, exceptions being children with neurological disorders, potentially. But, and our work, qualitative work, suggests that pediatricians are asking for guidance because they simply don't know what to do when a parent comes in and says they've already started melatonin on their child, and what do they do? And do they have the time and the expertise to really deliver the behavioral interventions the way that they should be done?
Yeah. No, that's really, really great point. And so we have a couple of questions that I wanted to get to in the chat. One of the questions was, can you elaborate on melatonin use in children who may have sensory issues, dyslexia, etc., which is kind of a big question, but if you could give a short answer to that.
Yeah, I mean, I think that's really a good question. To my knowledge, there's no data on that specific population. There are a few studies on children with ADHD, and the bulk of the evidence comes from children who have autism. There are several studies that look at extended release melatonin, which is not a product that's not available in the United States. And those studies were done on children with autism as well. But, there are no studies in children with psychiatric comorbidities. So we need to expand our universe of looking at this because, it's sort of like the horses out of the barn already. I mean, we've got to deal with this because it's just, I've been in practice for 30 plus years, and in the past 10 years, I rarely see a patient now who isn't on melatonin or hasn't tried melatonin.
Mhm.
And so, it's ubiquitous out there in the general population, and we have to address that. And it's got to probably come from multiple different sources to get that information out there.
Yeah, no, I agree.
May I comment on that
Please.
just
Please.
briefly?
Yes.
Yeah, Judy, in example, we don't have any data on children below 2 years of age, but in Italy at least, almost all pediatricians give melatonin to children below 2 years of age.
Wow.
And in my clinical practice, when I look at children who came to my office, all of them used melatonin in a different dosage, but this is a real problem. I never seen big side effects or severe side effects. So we can say that melatonin may be safe, probably, but there is a very large use, at least in Italy, of melatonin, and most of the sponsors of our meeting are the producer of melatonin, actually, over-the-counter
Really?
melatonin. That is another problem. So we don't have any more pharmaceutical companies, but over-the-counter products, and that will be a real problem even in the future. So we have to stop
Absolutely.
this. Yeah.
Yeah, that's a
Mm.
great point, Olivero, and your work. I've heard you talk about it's just so shocking to see the data that you've been able to collect on, not any, criticism necessarily of Italian pediatricians, but
Yeah.
you wonder what has allowed this to happen, and we're beginning to also know that the Hartstein article that was published last year, which is a survey study, showed that children remain on melatonin for 18 months, 2 years, more. So yes, in the short term, we don't see a lot of side effects, but who knows, how that affects brain development. Melatonin has a lot of different effects throughout the body, physiologic systems.
Sure.
On what I thought was really interesting, I saw a warning on I don't remember which pulmonary organization it was that said, don't give melatonin to children with asthma because it may increase reactive airway disease.
Yes.
So there's so much we don't know, and that's the small numerator, and the denominator of the sample size is just enormous.
Yeah.
So that's our job to address.
Thank you.
Yeah, Judy, I really appreciate you and appreciate all the work that you're doing, and so excited for you to continue this work on. And I'm conscious of time, and so I really will move on to Oliviero's talk now, but I just want to say a huge thank you, Judy. It was really always amazing to hear you speak.